Hello viewers, good day to all of you. This is Dr. BK for you with one more lecture on the upper limb, that is the elbow joint. So our learning objectives for today on elbow joint will be the type of elbow joint. So what type to this joint belongs, articulating surfaces, ligaments related to this joint, the nerve supply and blood supply of the joint, movements related to this elbow joint, and applied anatomy. Finally, we are going to discuss a few slides at the end with a short topic, that is the anastomosis around the elbow. Okay. Now, coming to the elbow joint, it is also called as the cubital articulation. It is actually a compound joint because more than 3 bones are involved. So it is also called as the cubital complex or the elbow complex. So mainly the humerus, then you have the radius, then you have the ulna. So the 3 bones are involved. So it is a humero-radial articulation, humero-ulnar articulation, then radio-ulnar articulation. The radio-ulnar articulation we are not going to discuss as it is not a part of the elbow joint. We are going to discuss it separately. So apart from that, if you look at it, the elbow joint is a hinge variety, synovial joint with a hinge variety. So which means it can permit movement only in one axis. So around the transverse axis, only one movement it is going to perform. So like the hinge of a door, the door can slide forwards and backwards. In the same way, your elbow joint can permit only one type of movement, that is the one angular movement, the flexion and the extension. The other name for the hinge joint, it is also called as the gingivitis joint. So as I told you, the 3 articulations are present, the elbow complex, and these 3 articulations share a common joint cavity. So the joint cavity is the same for the elbow as well as the superior radio-ulnar joints. If you look at the axis of the joint, it is not exactly lying on the transverse plane, but it slides downwards and medially. Okay. It is actually sliding downwards and medially. That is the axis of the elbow joint. And you are able to see this trochlea of the humerus. Again, it is not in line with the remaining part of the humerus. It somewhat projects anteriorly. The trochlea is projecting anteriorly. It is not in line with the remaining part of the shaft or the lower end of the humerus. So first we will see about the humero-ulnar articulating surface. The humero-ulnar articulating surface consists of the trochlea of the humerus. Above the trochlea of the humerus, you are able to see a fossa or depression which is actually called as the coronoid fossa, and then you have the trochlear notch of the ulna. So that is the trochlear notch of the ulna, which is actually formed by the olecranon process as well as the coronoid process. So the superior surface of the coronoid process and the anterior surface of the olecranon process, they both together form the trochlear notch. So in between these two, there is a narrow area here between this articulating part of the coronoid and the olecranon process, and it is a narrow strip. So the trochlea is made up of the medial flange, and that is actually called as the lateral flange. Okay, you call it as the medial flange and the lateral flange. You see very carefully, the medial flange actually dips downwards. Both are, again, the medial and lateral flange are not present along the same line. The medial flange is extending a bit downwards. Then you are able to see the coronoid process. Again, the coronoid process, even though it is projecting anteriorly, it is not exactly projecting anteriorly but somewhat oblique in nature. So the coronoid process is again somewhat oblique in nature. Okay. Then if you look at the articulating surface of the ulna, so that is mainly formed by the trochlear notch of the ulna. It is saddle shaped. So like the seat of a horse, it is actually saddle shaped, and when you look at it in the diagram or in this picture, it appears both are actually fitting perfectly, but it is not perfectly congruent. There is no congruency between the trochlear notch of the ulna and the trochlea of the humerus. In full extension, what happens is the lateral side of the olecranon, there is a bit of non-articular part. In full flexion, what happens is in the medial side of the ulna, there will be little bit of non-articular part. So these parts are not used. That means what? They are not perfectly congruent with each other. Okay. So that is what the saddle shaped, and it is not perfectly congruent between the two articular surfaces, that is the humerus and the ulna. The coronoid fossa, you are able to see, will be utilized by the coronoid process in full flexion, and it is also filled with the fat. Okay, because there is no articular cartilage lining the coronoid fossa. The olecranon fossa of the ulna, what happens is it fits into the olecranon fossa. The olecranon process fits into the olecranon fossa during full extension. Okay. So as I told you, there is a bit of the lateral surface and there is also a bit of medial surface which is not utilized in the full extension. In the full extension, it is actually the lateral part which is not utilized, and full flexion, the medial part is not utilized. So that is why they are not completely congruent. Now coming to the humeroradial part, the articulating surfaces are the capitulum of the humerus. So capitulum means head shaped. Then above the capitulum you have again a depression which is actually called as the radial fossa. Then the upper surface of the head of the humerus forms the inferior articulating surface for the humeroradial component. So here if you look at it, it appears something like a ball and socket only, because the head of the humerus is like a ball and the upper surface of the head of the radius is slightly concave or depressed, forming a socket. Okay, so for sake of description we can simply call it but as ball and socket, but it is really not so. So again during the full flexion, what happens is the head of the radius will come and articulate with the radial fossa, and in full extension the upper surface of the radial head articulates with the lower surface of the capitulum. So that is how it is actually articulating with the capitulum in the upper surface of the head. Okay, so this is during the flexion, and full flexion it may come and rest in the radial fossa. This is actually the circumference of the head of the radius, which is not utilized in the elbow articulation. This is mainly for the superior radio-ulnar joint, which we will be discussing in a separate lecture. Okay. So the anterior surface in flexion, it articulates with the capitulum of the humerus. Now coming to the ligaments of the elbow joint, only three ligaments. One is the capsular ligament, then you have the ulnar collateral ligament and the radial collateral ligament. They both are nothing but the thickenings of the capsule on the medial aspect and the lateral aspect. So capsule of the elbow joint, when you look at it, it is attached to the margins of the articulating surface. So around the lower end of the humerus, along the margins of the coronoid fossa and along the margins of the radial fossa. Okay, but what happens is the condyles are not present within the capsule. So the epicondyles are not covered by the capsule. So that is the upper attachment anteriorly. When you look at the distal or the lower attachment, it is attached to the margins of the trochlear notch of the ulna and it blends with the annular ligament of the head of the radius. Okay, so it blends with the annular ligament, which is again osteofibrous structure. So the capsule blends with the annular ligament. So this itself confirms that the elbow joint and the superior radioulnar joint has a single synovial cavity. Posteriorly, you are able to see the attachments of the capsule along the margins of the olecranon fossa. Okay, it is attached to the margins of the olecranon fossa. Then inferiorly, you are able to see it is blending with the annular ligament. Then here, slight thing, you are able to see an extension of the synovial membrane. We will come to that later. So little bit of synovial membrane is extending near to the neck of the radius. Then thickenings of the capsule on either side forms the medial and lateral collateral ligaments. It is also called as the radial and ulnar collateral ligaments. So interior of the joint cavity, you are able to see here, it is actually lined by the synovial membrane, that pink color one. You would see that pink color one, after lining the interior of the capsule, it is reflecting onto the bones, little bit onto the coronoid process and into the olecranon process. But you see that pink color is actually not seen here along the articular cartilage. So except the articular surfaces, it lines the interior of the bones and the capsule. Then extra synovial fat fills the three fossa. So that is your olecranon fossa, radial fossa and the coronoid fossa. These three fossa are actually filled with extra synovial fat. There will be outpocketing of the synovial membrane. I showed you that in the last picture, below the annular ligament, and it is actually surrounding the neck of the radius. So that outpocketing of the synovial membrane brings a protection to the head of the radius so that it doesn't slips out during the radioulnar joint movements when the head of the radius is going to spin inside the annular ligament. So that is about the synovial membrane of the elbow joint. Now coming to the ligaments, here you are able to see the medial thickening of the capsule is actually called as the ulnar collateral ligament. It has got an anterior band and it has got a posterior band, then it has got an inferior or a transverse band. Okay, so that means it is triangular in shape. The anterior band from the medial epicondyle to the coronoid process. Extension from the medial epicondyle to the coronoid process. Posterior band from the medial epicondyle to the olecranon process. From the medial epicondyle to the olecranon process. Then you have the transverse band which is extending from the anterior to the posterior band. So or to the coronoid to the olecranon process. Okay, so they form these three bands, and what happens is these bands is again related very intimately to the flexor carpi ulnaris muscle, flexor digitorum superficialis, and behind to the triceps muscle. So deep to this muscle you have the ulnar nerve, which is also very intimately related to this ulnar collateral ligament. Then posteriorly you are able to see a bursa, that is actually the olecranon bursa. Okay, so that is the olecranon bursa. There are three bursa around the elbow joint. One is the olecranon bursa. The other bursa will be seen near to the insertion of the triceps muscle, near to the insertion of the triceps muscle. So the olecranon process and the tendon of the triceps will be again be separated by a bursa which is present above the olecranon. Then in front you have a bursa between the tendon of biceps and the radial tuberosity. So because the tendon of biceps is going to get inserted into the radial tuberosity, there is a bursa between the tendon of biceps brachii and the radial tuberosity. Okay, so these are the three bursa which is related to the joint. Olecranon bursa, the other one between the tendon of triceps and the olecranon process, then other one between the tendon of biceps and the radial tuberosity. Now in between these three there are actually intermediate fibers, but it is somewhat weak, okay, between these bands. Coming to the next ligament, which is actually the radial collateral ligament. So here you are able to see the radial collateral ligament, which actually extends from the lateral epicondyle of the humerus, and inferiorly it blends with the annular ligament. Okay, so that is the thickening of the capsule laterally, which is the radial collateral ligament, or you can simply call it as the lateral collateral ligament. So two muscles which are very much intimately related to this is the origin of the supinator. So the supinator muscle fibers and the extensor carpi radialis brevis are very much closely related to this radial collateral ligament. So mainly this joint has only two ligaments. One is the radial collateral ligament and other one is the ulnar collateral ligament, apart from the capsule. Okay, so a view of the shoulder joint anteriorly you are able to see, that is the lateral view and that is the medial view. So that is how the capsule is actually present anteriorly, blending with the annular ligament. That is the ulnar collateral ligament and that is the radial collateral ligament. So you see the ulnar collateral ligament has got an anterior band, it has got a posterior band, and it has got an inferior band. Please note the olecranon bursa also, which is present here. Then you are able to see here the radial collateral ligament, which is actually stretching from the lateral epicondyle and blending with the annular ligament. So a little bit on the annular ligament we will see about it. So it is a ligament of superior radio-ulnar joint, making an osteofibrous ring, because this is the radial notch of the ulna which is bony and this is fibrous, so you call it as the osteofibrous ring, encircling the circumference of the head of the radius. So this part is for the articulation with the humerus, capitulum of the humerus, whereas the circumference is forming the superior radio-ulnar joint articulation, that also will be lined by the articular cartilage. So the annular ligament acts as a rim around which the head of the radius is going to spin, and it is actually a pivot joint. The nerve supply of the elbow joint is the ulnar nerve, median nerve and radial nerve. So these three joints are going to supply. Radial nerve will supply through the nerve to anconeus. Then you also have musculocutaneous nerve. Okay, So one is the musculocutaneous nerve, which is going to supply that. Radial nerve through branch to anconeus, and ulnar nerve will supply the ulnar collateral ligament, because it is intimately related to the ulnar collateral ligament. It gives a branch to the ulnar collateral ligament. Arterial supply is through anastomosis around the joint, which is actually called as the anastomosis around the elbow joint. So we are going to discuss about the anastomosis of the elbow joint after some time. So now coming to the movements of the elbow joint, we are able to see only two movements are permitted. One is actually the flexion and other one is actually the extension. So the range of the movement is, from a fully extended elbow, it can go up to 140 degrees. Okay, it can move up to the 140 degrees, and it might vary. So naturally, at most it can go up to 150 degrees. So flexion is actually stopped by the approximation of the two surfaces, that is your ventral surface of the forearm and the ventral surface of the arm. When they both approximate, then naturally the flexion is not possible beyond that. So flexion is mainly brought about by the biceps brachii muscle, the brachialis muscle, and the brachioradialis muscle. So BBB, 3 B's, okay, like big B. So 3 B's, that is the biceps brachii, brachioradialis, and the brachialis. So the brachialis is actually the prime flexor. It is a very powerful flexor, whereas biceps is only a weak flexor. Okay, brachialis and brachioradialis also helps in flexing the joint. Even though it is an extensor muscle, it helps in the flexion. Coming to the extension, what happens is, when your arm is at the resting position or in the anatomical position, when it is fully extended and in a straight line, then the extension has take place. The joint is in a closed pack position, so that means it is the most stable position of the joint. Are you able to understand? So further extension is actually prevented by the tension on the capsule. So fibers of the capsule, when they get tensed, then naturally what happens is further hyperextension or the extension is limited. And not only by that, it is also by the triceps muscle tension. So two muscles which bring about the extension of the joint is your triceps, and one more weak extensor of the elbow joint is the anconeus muscle. It is the anconeus muscle. Okay, now I already told you that in the humero-ulnar part of the elbow joint, the humero-ulnar component is not perfectly congruent, that is the trochlear notch does not completely articulate with the trochlea of the humerus. So during flexion, what happens is there will be a mild pronation, and during extension there will be also a mild supination, so which can be also considered as minimal rotation along the humero-ulnar part. Okay, other than that, the only movement is the flexion and extension of the joint, because it is a uniaxial joint. So now we will come to one more structure, one more concept of this elbow joint, which you see here as the carrying angle. So what is actually the carrying angle? When you are able to see the long axis of the arm and the long axis of the forearm, they are not in a straight line. You are able to see, so they form an angle, and the angle is open laterally. Okay, the angle is open laterally and it is an obtuse angle. That is actually called as the carrying angle. So angle between the long axis of the arm and angle between the long axis of the forearm. So in a fully extended elbow and In a supinated forearm, you can see this obtuse angle. Why in a supinated and a fully extended elbow? If you pronate, then the angle disappears. Okay. Why it is called as the carrying angle is because of this carrying angle, your forearm is not or little bit away from your hip or thighs. So to carry heavy objects, this carrying angle helps. Are you able to understand? Okay. Now, it is wider in females. The carrying angle is wider in females. But now, the latest studies tell that no, it is not so. It is believed that it is wider in females. One reason for that is due to the females have a wider hip, so they are more away. Your forearm is more away from the hip region. But now there is actually a controversy that no, both the males and females, it is the same. But it may differ between the individuals. The carrying angle actually might differ between the individuals. So the angle, obtuse angle is 165 to 170 degree. As I already told you, it is an oblique and obtuse angle. And there might be a difference of 10 to 15 degrees. So here you are able to see the long axis of the humerus. And if you take the long axis of the ulna, both are actually not meeting with each other, and you form an angle here. That is actually the carrying angle. Now why actually the carrying angle is because what produces this carrying angle? The medial flange of the trochlea extends below up to 6 millimeter downwards as compared to the lateral flange of the trochlea. So obliquity, you are able to see one obliquity is there. Then if you look at the coronoid process of the ulna, it is not projecting anteriorly, but it is somewhat anterolaterally obtuse again. So these two factors bring about the carrying angle so that the ulna is not aligned in line with the humerus. Okay. Now, this is actually your normal carrying angle. Now, when there is an increase in angle or when there is a decrease in angle, you call it as cubitus valgus and cubitus varus. Okay. So, cubitus valgus and cubitus varus. Increase in the angle is actually called as cubital valgus and decrease in the angle is actually called as the cubitus varus. So, this might occur in the fractures of the elbow. The carrying angle might disappear. The decreased angle is also called as gunstock deformity, and usually when we measure the angle, your dominant limb, it is slightly more than the non-dominant limb. For example, if you are a left-hander, then the carrying angle is slightly more as compared to the right hand. So coming to the radiograph of the elbow joint, you are able to see here, this is a plain radiograph where you are able to see the elbow area, the medial and the lateral epicondyles, the coronoid process and the olecranon process superimposed over the coronoid fossa. Okay. So it is actually backside, but it is superimposed in a radiograph. So trochlea of the humerus, you are able to see here, medial flange, you are able to see that is dipping downwards, and the lateral flange. This is the coronoid process I told you. This is the head. This is the lateral capitulum. You are able to see here, radial tuberosity, neck of the radius. This is the circumference of the head of the radius, and you see the upper surface of the head is somewhat slightly concave. So that is why I told you it can be just called as the ball and socket based on the shape of the articular surfaces. Lateral view of the elbow, you are able to see here, you are able to see the lateral epicondyle, the medial epicondyle. On the other side, you are able to see superimposed. So that is the lateral epicondyle. This sharp line is the supracondylar ridge. So this is the olecranon process and the coronoid process. Neck of the radius, tuberosity of the radius, you are able to see here. Okay, so this is the lateral view of the elbow, and this is actually the anteroposterior view of the elbow. Here, so I just want to know certain things, so I put an X-ray of a child which is only 4 years old. So when you look, most of the epiphyses of the long bones are not fused. So you are able to see the capitulum, you are able to see the head of the radius. So when you look at an X-ray, this might be separated because there will be the epiphyseal plate of cartilage, and it should not mistakenly identify it as a fracture. So fracture means the margins will not be smooth like this. You don't get a smooth margin. That is one thing. Now second thing is, I want you to concentrate on the head of the radius, which is not fully formed. The head of the radius is going to get completely ossified only after the 6 years of age. Okay. So because of that, what happens is the head of the radius might get dislodged very easily from the annular ligament. So from the superior radio-ulnar joint, which is more common in children below the 6 years of age, and that is actually called as the pulled elbow. So we will be discussing about this pulled elbow again in the superior radio-ulnar joint. So coming to the applied anatomy of the elbow joint, fractures of the joint are very common. Supracondylar fractures, then dislocation of the elbow. So supracondylar fractures might be of 3 types. One is a hairline crack, you are able to see here. Here is anterior dislocation, or not anterior fracture, where the anterior wall is dislocated, which is type 2, and type 3 is both the anterior and posterior part of the humerus is actually fractured. Dislocations of the elbow joint, as you are able to see here, it might be inferior dislocation, or it might be superior dislocation, or it might be medial and lateral dislocation. Okay, so fractures or supracondylar fracture is most common when you fall on an outstretched hand. Okay, now how do you distinguish between the supracondylar fracture or whether it is a elbow dislocation? Now one thing is, in the fracture of the humerus, supracondylar fracture, there might be shortening of the arm, whereas in elbow dislocation there will not be any shortening of the arm, but there might be shortening of the forearm. Okay, that is one thing. Second thing is the relationship between the two epicondyles and the olecranon process will be disturbed in case of the elbow dislocation, whereas in supracondylar fractures, this triad, that is the two epicondyles and the olecranon process, this triangle will not be disturbed. So I will actually discuss about this then. So in the dislocations or in the fractures, supracondylar fracture, what happens is you are able to see the blood vessel might get compressed and even the nerve might get compressed. You have vascular symptoms as well as nerve symptoms. So in vascular symptoms, what happens is, if the brachial artery is compressed, then naturally blood supply is lost and you get the condition which is called as the Volkmann's ischemic contracture, which I have already described in the brachial artery, applied anatomy. So entrapment of ulnar nerve, which might lead to claw hand, or entrapment of the median nerve might lead to pronator teres syndrome or other associated injuries related to the median nerve. So here what happens is medial epicondylar fracture, again it is the involvement of the ulnar nerve. Yes. So here when you are able to see, I told you the relationship between the two epicondyles and the olecranon process should form a triangle, and in a flexed elbow it should be 90 degrees. So if you draw a transverse line between the two epicondyles and you draw a vertical line from the olecranon process, they will form a 90 degrees. In full extension, complete extension, when you see that, what happens is all the three lying in a straight line So there is no degree, 0 degrees and all lying in a straight line in extension. So these two you should check whether there is an elbow dislocation. In elbow dislocation you won't get this 90 degrees triangle, perfect triangle. Okay, but in supracondylar fractures what happens is this triad relationship is not disturbed. Then other applied aspects, so cubitus valgus decrease in the angle is due to injury to the epiphysis of the lateral epicondyle. Okay, so because of the lateral epicondyle injury, what happens is there is a decrease in the angle which might lead to the ulnar nerve injury. Okay, so it might lead to ulnar nerve injury, and tennis elbow is lateral epicondylitis. So it is actually called as the lateral epicondylitis in case of the tennis elbow. Okay, sudden what happens is pronation of the forearm might lead to lateral epicondylitis, more common in tennis elbow, tennis players. Then golfer's elbow is repetitive flexion which is leads to inflammation of the common flexor origin, which may lead to the common flexor origin in the golfer's elbow, more common in golf players. This is due to medial epicondylitis. So inflammation of the medial epicondylitis. Lateral epicondylitis is actually due to the inflammation of the radial collateral ligament. Then you have one more type which is actually called as the floating elbow or side swipe fracture. So here you are able to see inflammation of the lateral epicondylitis or the radial collateral ligament in tennis elbow, and medial epicondyle strained and inflamed in case of the golfer's elbow. So that is the posterior dislocation, which is actually called as the side swipe injury or the floating elbow. Then coming to ligament of Struthers, it is actually called as arcade of Struthers. Sometimes a facial band might connect the brachialis muscle and the triceps brachii muscle. Okay, so the ulnar nerve which is going to pass posteriorly piercing the medial intermuscular septum might get trapped there. It might get compressed. So what happens is entrapment neuropathy again might lead to ulnar claw hand. So it is actually called as the ulnar claw hand, and it might also leads to Froment sign. So here you are able to see the Froment sign. How do you test the Froment sign is you ask the patient to hold the paper with the thumb and the index finger, and you try to pull the paper. The examiner has to pull the paper, but he has to hold the paper against resistance. Flexion of the thumb should not take place. If the flexion of the thumb is actually taking place, then there is a ulnar nerve injury because the thumb is bending. Why? Because the adductor pollicis muscle of the thumb, of the thumb has lost its nerve supply due to ulnar nerve injury, so he is not able to adduct his fingers or adduct the thumb strongly. So in an attempt to hold the paper, he is using the flexion. So thereby flexion of the thumb takes place. That is Froment's sign. Then subacromial bursitis, inflammation of the bursa or subacromial bursitis, more common in students, because students, what happens is they rest their elbow on the table for a very prolonged time in writing and such activities. Minor's elbow, because minors, they will be moving underground, so they have to crawl with their elbow might get inflamed. So in student's elbow and minor's elbow, it is actually the inflammation of the subacromial bursa. It is called as a subacromial bursitis. So these are all the applied aspects of the elbow joint. Now we will come to the anastomosis around the elbow joint, because this can be actually expected as a separate short note. So if you look at most of the joints in the long bones, that is the limbs, the blood supply is in the form of anastomosis. For example, in the shoulder joint, we have seen anastomosis around the scapula. Same way in the elbow, anastomosis around the elbow joint. You have anastomosis around the wrist. Same way in the lower limb, you have anastomosis around the hip, knee and ankle. Because during the movements, if there is a single arterial stem, it might get compressed or kinked between the bones and the blood supply might be compromised. So around the elbow, it is present in the front of medial epicondyle, behind the medial epicondyle. Same way it will be present in front of the lateral and behind the lateral epicondyle. Medial epicondyle, it is anterior branch of inferior ulnar collateral artery and anterior branch of superior ulnar collateral artery. These two are going to anastomose with the anterior ulnar recurrent artery of the ulnar artery. So these two are branches of brachial artery and this is a branch of the ulnar artery. Behind the medial epicondyle, posterior branch of inferior ulnar collateral and superior ulnar collateral with posterior ulnar recurrent artery. So here are able to see medial epicondyle. In front of the medial epicondyle, anterior branch of superior ulnar collateral and inferior ulnar collateral, both are branches from brachial artery, with the branch of ulnar recurrent artery, which is again a branch of the ulnar artery. Anterior branch of ulnar recurrent artery with the anterior branch of superior ulnar collateral and inferior ulnar collateral. Behind the medial epicondyle, it is the posterior branch of superior ulnar collateral and posterior branch of inferior ulnar collateral. Superior and inferior ulnar collateral, posterior branch, which is going to anastomose with the posterior branch of ulnar recurrent artery. So posterior ulnar recurrent artery behind the medial epicondyle. Then coming to the lateral epicondyle, branch from the profunda brachii artery, anterior descending branch, and branch from the radial artery, that is the radial collateral branch in front of the lateral epicondyle. Behind the lateral epicondyle, radial collateral artery and the interosseous recurrent branch from the posterior interosseous artery. Okay. So here are able to see in front of the lateral epicondyle. So branch from the profunda brachii artery, descending branch from the profunda brachii artery will anastomose with the radial recurrent artery. Behind it is actually the collateral branch will anastomose with the interosseous recurrent artery, which is a branch from the posterior interosseous artery. So branch from the posterior interosseous artery, it is the interosseous recurrent artery. In front of the epicondyle, it is from the radial artery, that is the radial recurrent artery. We anastomose with the branches of anterior descending profunda brachii artery, which is a branch, and radial collateral artery, which is actually behind the lateral epicondyle. Here, medial epicondyle, we have discussed the branches of superior ulnar collateral, inferior ulnar collateral with the branches from anterior and posterior ulnar recurrent arteries. There is also one more transverse anastomosis above the olecranon fossa, transverse branch from the radial collateral, which is a profunda brachii artery, transverse branch from the posterior ulnar collateral. So you see the posterior ulnar collateral also giving a transverse branch, radial collateral and posterior ulnar collateral anastomosing with the posterior branch of inferior ulnar collateral. So inferior ulnar collateral will give a transverse branch, posterior ulnar recurrent will give a transverse branch, radial collateral will give a transverse branch. So all these takes part in the transverse anastomosis, which is above the olecranon process. So this is about the anastomosis around the elbow joint. So thank you very much for listening to this lecture, and we will meet again shortly in one more lecture.